And just from your perspective, how do you think clinicians should start incorporating emerging evidence about sex differences in immune aging to real world decision making today, even before all of the data is definitive? Should it play a role at all?
I think what is clear now is that we need to record the information.
Mm,
As I mentioned earlier, I think we have a complete lack of information in terms of diet, exercise, um, lifestyle factors. So having questionnaires, having app, having wearables that can record that will allow us then in the future to adjust the therapies based on that. And so without that, we want to be able to analyze. We're not going to be able to learn. And so at least in my clinical practice and in my team, we're starting to implement that.
mm. I want to talk a little bit about CAR T cell therapy specifically as it relates to your work. So your lab focuses heavily on mechanisms of relapse and resistance after CAR T cell therapy and hematologic malignancies. How do host factors like sex and aging intersect with those resistance mechanisms?
Yeah, no, that's a fantastic question about that. So we know that I'm gonna start with diet and microbiome. We know that, and we know that because we did the study, that if you have less diversity in the gut microbiome, if you have certain specific taxa of bacteria, you have a different outcome in terms of efficacy and toxicity. So clearly, there is an influence of the microbiome. Another evidence is the fact that if you look at patients who have used antibiotics before CAR treatment, in the 4 weeks before, they have a way poorer outcome as compared to the one that did not. So this is the first evidence, for example, that and I'm talking specifically about CAR T cell. And so first evidence. Second evidence is about sex. Basically, most trials of CAR T cell show a trend that could be or cannot be statistically significant, but there is a clear trend in a better response rate and a trend of better progression-free survival in female patients.
Mm,
So we know that. That's evidence.
mm,
We don't have any data on exercise. We have data on inflammation. As I mentioned, baseline inflammation is correlated with poor outcomes. Aging is actually interesting because what is aging? It's just the age. Well, you know there are people that they are 80 years old and they look like 50, and vice versa. They are 55 years old, they look like they are 90. And so age, measuring ages just by years, it's not gonna work. So if you look just at the age in terms of when the patient was born, we don't see difference in our CAR T cell therapy. What we're gonna start to do, we're gonna have to have more scores that will tell you what's the fitness of the patient, what's the more the biological age, and that is gonna affect for sure because the older patient that we're treating with CAR are usually very fit older patients. We're not treating the one that are not fit. So again, age as years is not correlated with outcome right now, but I think we need to look at biological age. And so we cover aging, we cover inflammation, diet, exercise. Obesity is interesting because obesity, for example, in immune checkpoint has been actually associated with better outcomes. What we are starting to see now in the setting of CAR T cell is that the obesity per se is not such a factor that affects outcome, but what really affects outcome is the reduction of muscle mass. So what we call sarcopenia. So having less muscles is associated with poor outcomes. So again, if you measure just the weight, might not be indicative. If you have a very fit person with a lot of muscles, they weigh a lot. They weigh more than actually adipose tissue. And so just the weight per se is not indicative of that. And so we know patients that have less muscles do poorly with CAR T cells. So these are actual data on CAR T cells.
mm.
So as you can see, we start to have data on these factors, and now they affect cancer immunotherapy.
Interesting. And just looking ahead, what collaborative efforts or consortia do you think are needed systemically to study sex, aging, inflammation across large immunotherapy cohorts?
Yeah. So you got it exactly right. We need a lot of numbers because being these not so these are important factors, but they're not going to be driving huge differences in a limited number of patients. So only when you have hundreds of patients, you can start see these clear trends. And so from one case is pulling together cohorts of patients. The other point is that now we're starting to analyze imaging, so CT scan, PET scans, and you can get them because they're routinely requested to our patient, and you can actually measure the muscles, the adipose tissue. And so you can get that information. If you have a large cohort, you can start correlating. And then, as I mentioned before, getting more information about diet and exercise will sort of feed the system, and we'll be able to analyze that as well.
Wow. Well, this has been an amazing conversation. Thank you so much for joining us here on MD Newsline Podcast. It's been a pleasure.
Thank you for having me.